Let me tell you about a patient I'll never forget. His name was Marcus, 61 years old, retired firefighter out of Chicago, tough as nails. He came into my office one Tuesday afternoon, and I remember he sat down, looked me dead in the eye, and said, "Doc, I feel fine. My wife made me come in." Classic. I've been practicing medicine for over 30 years, and I can tell you, those are the words that make doctors like me the most nervous. Because "I feel fine" is exactly what people say right before we find something they didn't know was there. Marcus had been waking up 2-3 times a night to use the bathroom for about a year. He figured it was just getting older. He'd noticed his urine looked a little foamy sometimes, but he figured that was just because of the angle, or because he'd been drinking a lot of coffee. He hadn't thought twice about it, neither had anyone else. When I ran his labs, his eGFR, that's the number we use to measure how well your kidneys are actually filtering your blood, had already dropped to 51. He was stage 3 chronic kidney disease, had been silently losing kidney function for years, and he had absolutely no idea. That's the story I want you to sit with for a second before we get into anything else. Because Marcus is not unusual. He is the rule, not the exception. Here's what the numbers tell us. More than 1 in 7 American adults has chronic kidney disease right now. That's tens of millions of people. And of all of them, 9 out of 10 don't know it. 9 out of 10. Think about that. If 10 of your friends have CKD, 9 of them are walking around with no clue. The disease can silently destroy your kidneys over 10, 15, even 20 years before it reaches what we call end-stage kidney disease, the point where your kidneys have lost 85 to 90% of their function. By the time most people get diagnosed, we're already playing catch-up. That's why I'm making this video, not to scare you, but because after more than 30 years of sitting across from patients and delivering news that came way too late, I'd rather you know this now. Catching kidney disease early is genuinely your best shot at keeping it from getting worse. And the early signs? Most of them are things you can notice yourself right at home with zero equipment. You just have to know what to look for. So let's talk about all of it. The 5 early signs, what they mean, when to worry, and what to actually do about it. I'm going to give you the specifics that most videos like this skip over, because I think you deserve a straight answer, not just a vague warning to see your doctor. Let's start with number 5, foamy urine. Now, before anyone gets anxious, not all bubbles in the toilet mean something's wrong. If you've got a strong stream and the water just kind of foams up, and then those bubbles pop within 30 to 60 seconds, that's normal. Happens to everybody. What I want you to pay attention to is this: persistent, layered foam. Small to medium-sized bubbles that sit there and just don't go away after 2 to 3 minutes. That's different. That's your body potentially telling you something. The reason this happens in kidney disease is a condition called proteinuria, which just means protein in the urine, specifically a protein called albumin. Under normal circumstances, albumin stays in your bloodstream, doing its job. Your kidneys are supposed to filter it back in and keep it there. But when the kidneys get damaged, that filtering mechanism breaks down and albumin starts leaking out through your urine, and protein in water creates foam. Same principle as egg whites. Protein makes things frothy. Here's the clinical reality. Albuminuria is one of the earliest detectable signs of kidney disease. It can show up even in stage 1 CKD, when your overall kidney function still looks relatively okay on a blood test. It's a canary in the coal mine. Now, I'll be honest with you, only about 1/3 of people who notice foamy urine actually have significant proteinuria when we test them. So it doesn't automatically mean the worst, but it means you should get it checked. A simple urine dipstick test at your doctor's office can tell you within minutes whether there's protein present. That test costs almost nothing, and it could catch something 10 years before it becomes a crisis. Number 4, Nocturia. Fancy word, simple concept, getting up to pee at night. And I know what a lot of you are thinking. You're thinking, "Doc, I'm in my 60s. Everybody gets up at night." And you're not wrong that it becomes more common as we age. But here's the line I want you to draw for yourself. If you're getting up 2 or more times per night to urinate consistently, that is worth paying attention to. Once maybe, twice or more regularly. That's nocturia, and it has clinical significance. Here's what's happening in the kidney. CKD disrupts the way your kidneys manage salt and water balance. Normally, your kidneys concentrate your urine more at night so you can sleep through without interruption. That's supposed to happen. But when kidney function starts declining, that ability gets impaired. The kidneys start producing more urine at night, a condition called nocturnal polyuria, and your bladder keeps filling up when it shouldn't be. A 2023 survey study actually showed that eGFR, remember, that's our kidney function score, was meaningfully lower in people with nocturia compared to those without. It correlates. The more times you're getting up at night, the more that correlates with declining function. Now, other things can cause nocturia too. Diabetes and enlarged prostate, which is extremely common in older men, urinary tract infections, even just drinking too much fluid late in the evening. So I'm not saying nocturia equals kidney disease. I'm saying if you're getting up 2 or more times a night and you don't have a clear explanation for it, put it on your list of things to mention to your doctor. Don't dismiss it as just getting older. That's what Marcus said. Don't be Marcus. Number 3, blood in the urine. The medical term is hematuria, and it comes in 2 forms. Gross hematuria, that's when you can actually see it. Your urine looks red or pink or maybe brown like iced tea. That one most people don't ignore because it's alarming to look at. If you ever see that, call your doctor that day. Don't wait. But the one that gets missed? Microscopic hematuria. You can't see it with your eyes. The urine looks completely normal. The only way to find it is through a urinalysis, a urine test. And here's why this matters. A 2018 study found that the presence of microscopic hematuria in patients with moderate CKD was associated with significantly increased risk of disease progression and death within the first 2 years of testing. And the prevalence of hematuria went up as eGFR went down. In other words, the worse the kidney function, the more likely blood was to be present. They go hand in hand. This is exactly why I stress annual urine testing for my patients, especially men over 55 with any risk factors, because you will not catch microscopic hematuria on your own. It requires a test, and a routine urinalysis is one of the cheapest, most straightforward tests we do. We're talking under $30 at most labs, and many insurance plans cover it completely as part of an annual physical. I hear a lot of people say they're worried about what healthcare costs. I get it. I understand that the financial burden of kidney disease treatment is staggering. Medicare spent over $75 billion in 2020 on CKD patients alone. But a $30 urine test done annually is as close to free prevention as medicine gets. The economics make sense. Number 2, decreased urination. This one is a little different from the others because it's less of a subtle sign and more of a red flag that something acute may be happening on top of existing kidney problems. Let me explain. CKD by itself doesn't usually cause you to stop producing urine. In fact, as we talked about, it often causes you to produce more. But if you already have chronic kidney disease and then something else hits, severe dehydration, an obstruction, a urinary tract blockage, you can develop what we call acute kidney injury on top of chronic kidney disease, and that can cause low to very little urine output. So if you notice you're urinating significantly less than usual, not once or twice, but over a period of a day or two, and you haven't just been drinking a lot less fluid, that is something to take seriously. Call your doctor. If you can't reach them, go to urgent care. Don't sit on it. Acute kidney injury on top of CKD can cause permanent damage very quickly. Number 1, flank pain. This is the pain that sits on the side of your body, between your lower ribs and your hip. Think of the area where your kidneys actually live, which is on either side of your spine, in your mid to lower back. Pain in that region, especially if it's deep and dull rather than muscle soreness from, say, lifting something heavy, deserves attention. Pain is actually more common in people with CKD than in the general population, but the reasons vary. The most common kidney-related condition that causes chronic flank pain is polycystic kidney disease, a genetic condition where cysts grow on the kidneys and cause them to enlarge. But other conditions associated with CKD can also produce this kind of pain. Kidney infections, inflammation, reduced blood flow to the kidney, tumors, kidney stones. All of these both cause flank pain and increase your risk of developing CKD if left unaddressed. I'll be straight with you about something. A lot of men, especially guys of a certain generation, tend to compartmentalize pain. They chalk it up to "must have slept wrong" or "it's just my back." And sometimes it is. But if you've got flank pain that keeps coming back, or if it's combined with any of the other signs I've described, that combination is worth a conversation with your doctor. Now let me shift gears and talk about who's most at risk, because this is where I want all of you to really pay attention. The two biggest risk factors for chronic kidney disease in American adults are hypertension and diabetes, not rare conditions, not obscure diseases, the two most common chronic conditions in this country, especially in men over 50. An estimated 1 in 5 people with high blood pressure will go on to develop CKD. For diabetes, it's 1 in 3. If you have both, and many of you do, your risk is compounded significantly. Here's the thing about blood pressure and kidneys that most people don't realize. It goes both ways. High blood pressure damages kidney blood vessels, reducing function. And as kidneys lose function, they regulate blood pressure less effectively, which drives blood pressure higher. It's a feedback loop that can spin out of control without you knowing. The KDIGO 2024 clinical guidelines, these are the gold standard recommendations from kidney specialists worldwide, now recommend keeping systolic blood pressure below 120 millimeters of mercury in CKD patients. That's tighter than what most people think of as normal. If your doctor has been telling you that 130/80 is fine, you might want to have a more specific conversation about your kidneys. Other risk factors worth knowing: cardiovascular disease, heart failure, a personal history of acute kidney injury, kidney stones, especially recurring ones, abnormalities in the urinary tract, HIV, lupus, certain medications used long-term, and family history of kidney disease. Some research also points to environmental factors in geographic regions with higher CKD prevalence, and certain medications that many of you may be taking for other things. NSAIDs like ibuprofen and naproxen and proton pump inhibitors like omeprazole can further damage kidneys over time when used chronically. I'm not saying stop your medication without talking to your doctor. I'm saying if you're taking those regularly, your kidney function is worth monitoring. Let me talk about testing now, because this is where we go from suspicion to certainty. There are 2 essential tests for kidney disease, and I want you to know them by name so you can ask for them specifically. The first is a serum creatinine blood test, which gives us your eGFR, estimated glomerular filtration rate. Creatinine is a waste product your muscles produce naturally. Healthy kidneys filter it out efficiently. When kidneys start struggling, creatinine accumulates in the blood and your eGFR goes down. Here's the scale. eGFR above 90 is normal. Between 60 and 89 is mildly reduced. Between 45 and 59 is stage 3 ACKD. Between 30 and 44 is stage 3B. Below 15 is kidney failure. Marcus came in at 51. He'd been losing ground for years without a single symptom. This test, a standard blood draw, would have caught it earlier if he'd been getting it annually. You may also hear about blood urea nitrogen, or BUN, as another kidney marker. It's fine as a secondary indicator, but I want to be honest with you. BUN is less reliable. It gets affected by dehydration, high-protein diets, GI bleeding, heart failure, and other things that have nothing to do with your kidneys. Serum creatinine and eGFR are your most reliable numbers. The second essential test is a urine albumin to creatinine ratio, abbreviated UACR. This measures exactly how much albumin is leaking into your urine, and it can detect early kidney damage even when your eGFR still looks acceptable. It's especially important for people with diabetes or hypertension who should be getting this test annually as standard of care. If your doctor isn't ordering this at your annual physical and you have those risk factors, ask for it by name. Evidence of kidney damage, by clinical definition, includes protein or blood in the urine, abnormal microscopy on urine exam, structural changes visible on kidney imaging or biopsy, certain electrolyte abnormalities, like low potassium or low phosphate that doesn't have another clear cause, and a history of kidney transplant. Now, when should you start screening? If you have type 1 diabetes, screening for CKD should begin 5 years after your diabetes diagnosis. If you have type 2 diabetes, which is far more common in older men, screening should start at the time of diagnosis. If you have high blood pressure or cardiovascular disease, annual kidney screening should be part of your routine right now, not eventually, now. A recent study found that people who got diagnosed earlier, before their symptoms pushed them in, had significantly slower disease progression than those diagnosed late. The earlier the diagnosis, the more we can do. Here's something I want to be clear about when it comes to treatment, because I know some of you are already dealing with this. There is no cure for chronic kidney disease. I won't tell you otherwise. What we're doing is managing it, slowing the decline, protecting what's left, and keeping your quality of life as high as possible for as long as possible. And the earlier we catch it, the more effectively we can do that. Medications play a key role. Blood pressure control is paramount. Again, target below 120 systolic. For blood sugar, the KDIGO 2022 guidelines recommend HbA1c below 6.5% for stage 1 CKD patients and adjusting targets for more advanced stages. There are also newer drug classes, SGLT2 inhibitors, originally developed for diabetes, that have shown remarkable kidney protective effects in both diabetic and non-diabetic CKD patients. If you haven't discussed these with your nephrologist or primary care doctor, it's worth bringing up. Lifestyle changes matter more than most people give them credit for. I've seen patients genuinely slow their CKD progression through consistent, sustained lifestyle modification. What does that actually look like? Moderate intensity physical activity for at least 150 minutes a week. That could be brisk walking, cycling, swimming, whatever you can do consistently. A diet that leans toward whole plant-based foods and away from ultra-processed products. That doesn't mean you have to become a vegetarian. It means choosing grilled fish over processed deli meat. Cooking at home more often, watching your sodium intake, which directly affects blood pressure. Cutting back on alcohol. And if you smoke, I know this is a conversation many of my patients have heard before. Quitting is one of the most powerful things you can do for your kidneys, your heart, and your lungs all at once. I also want to say something about the financial piece, because I've heard from so many patients over the years who feel like the healthcare system is working against them economically. That frustration is real and it's valid. The cost of dialysis, the cost of medications, the monthly follow-ups, it adds up fast. But here's the counter-argument I'd offer you. Annual blood and urine screening, early management with lifestyle changes and basic medications, that is a fraction of the cost of dialysis or a kidney transplant. The goal of everything I'm describing today is to help you never get to that point. Prevention and early management is the most cost-effective path by a mile. If you're worried about cost, talk to your doctor about what's covered under your insurance plan. A lot of basic kidney screening is covered as preventive care with no out-of-pocket cost. If CKD does progress to the most advanced stage, stage 5, what we call end-stage kidney disease or kidney failure, the decision to start renal replacement therapy involves a real conversation between you and your doctor about your health, your values, and your goals. The two main options are dialysis and kidney transplantation. Hemodialysis uses a machine to filter your blood, typically 3 sessions per week, each about 4 hours. Peritoneal dialysis uses a catheter placed in the abdomen and allows for more flexibility, often done at home. Neither is easy, but both can sustain life and maintain reasonable quality of life when managed well. The KDIGO 2024 guidelines recommend beginning the conversation about renal replacement therapy when eGFR drops below 15 to 20. You want to be prepared, not blindsided. Let me bring this back to where we started. Let me bring it back to Marcus. After we got his diagnosis at stage 3, Marcus and I sat down and had a real talk. We adjusted his blood pressure medication. We cleaned up his diet. He was a big red meat and processed food guy, which is common, and we worked on that gradually. We got him walking 30 minutes a day, which he actually ended up enjoying once he got into the habit, and we monitored him closely. 3 years later, Marcus came in for his follow-up, and his eGFR had gone from 51 to 54. Small number, but in CKD, that's not decline. That's stabilization. That's a win. He still wakes up once a night to use the bathroom, but it's once, not 3 times. His wife, he told me, no longer has to make him come in. That's what early detection can do. That's why these 5 signs matter. So let me give them to you one more time, clean and simple. Number 5, foamy urine. Persistent foam or bubbles in the toilet that don't dissolve within 2 to 3 minutes could be protein leaking from your kidneys, worth a urine test. Number 4, nocturia. Getting up 2 or more times per night to urinate on a consistent basis, not just once, not just after you had a few beers, regularly, could indicate your kidneys are struggling to concentrate urine overnight. Number 3, blood in the urine, either visible, urine that looks red, pink, brown, or tea-colored, or invisible, only detectable on a urine test. Both forms can be an early sign of kidney damage. Number 2, decreased urination. Producing significantly less urine than usual over a day or two without an obvious reason like reduced fluid intake. This can signal an acute problem on top of chronic kidney disease. Number 1, flank pain. Deep, recurring pain in the side of your abdomen, between the ribs and the hips, especially if you have any of the other signs or risk factors we discussed. If you recognize yourself in any of these, or if you have high blood pressure, diabetes, cardiovascular disease, or a family history of kidney problems, I want you to make a phone call tomorrow morning, not next week. Tomorrow. Ask for a serum creatinine with eGFR and a urine albumin to creatinine ratio. That's it. 2 tests. You could have results within a day or 2, and if everything comes back clean, great, you get peace of mind. But if it doesn't, you've just given yourself the most valuable thing any patient with CKD can have: time. Chronic kidney disease doesn't have to be a death sentence. It doesn't have to mean dialysis. It doesn't have to mean the end of a good life. But it does require that you know it's there. It requires that you take it seriously before your body forces you to. After 30 years of doing this work, I can tell you, the patients who do best are the ones who showed up before they had to. Don't wait for a crisis. Don't wait until you feel bad. Be the person who calls tomorrow. Take care of your kidneys, people. They've been quietly taking care of you your whole life.